Welcome to CE Conversations, a clinical podcast presented by Creative Educational Concepts, designed to improve clinician performance and optimize patient outcomes. This session, Optimizing Early Breast Cancer Outcomes in the Community Setting, an expert review of emerging therapies and evolving standards of care in HR-positive, HER2-negative disease, is accredited for 1 hour of ACCME, ANCC, and ACPE credit, and is supported by an independent educational grant from Lilly. To earn CE credit for this activity, please visit the link in our show notes to complete the post-test and activity evaluation. And with that, we'll turn it over to our expert faculty.
Hello, and good morning, I think, for pretty much everybody, or good beginning of good afternoon. Welcome to this, I think, very nice talk on trying to apply emerging data as well as established data to clinical practice. I'm really looking forward to talking to you today and hearing from you about how you would apply this data to clinical practice. I'm Hope Rugo at the University of California, San Francisco's Comprehensive Cancer Center, where I'm a breast cancer oncologist and clinical trialist. These are all of the disclosures of the different staff that are involved in this program. There are different presenters who have worked across the United States on these programs, the peer review and CEC staff. Creative Educational Concepts works on CME education, and this is supported by an independent educational grant from Lilly, but the slides were developed independently by the faculty in this program, along with the tremendous staff from Creative Educational Concepts. It's accredited for 1 AMA PRA Category 1 credit, and for pharmacists, 1 ACPE contact hour, and for nurses, 1 contact hour. And to obtain credit, a link appears at the end of the webinar. Click on the link to complete the evaluation, which you need. It's higher risk. It's also identifying predictive factors. So we're going to look at the current landscape in patients with this subtype, including established and emerging evidence that for novel therapies in the adjuvant setting, the consensus guidelines and FDA-approved indications. And we also, of course, as always, want to understand treatment-related adverse events with oral therapies and how we can mitigate the toxicity as well as improve adherence. We're going to use real-world patient case examples to design on-label treatment plans for patients at a high risk of recurrence, emphasizing how we can communicate best with our patients and coordinate with our multidisciplinary community-based teams, and then evaluate adaptive approaches for the most important factor of all of this with oral therapy, which is promoting adherence and persistence to oral anti-cancer therapies, understanding the reasons for non-compliance and the impact of patient counseling and shared decision-making. So we're going to start with a pretest. So you're going to be doing these Zoom polls as we go along. So we'll get used to them here. So all of the following are true about HR-positive, HER2-negative early breast cancer, except the following. It's the most common breast cancer subtype. 5-year relative survival for regional disease is about 90%. Single agent chemo has long been the backbone for adjuvant chemo, and recurrence is a key consideration for adjuvant treatment selection. So vote. It will help us get through things. Don't worry too much about your voting. Just quickly vote. Okay, so we have about 25 out of, there's 40 on, but some, of course, are staff, but 25 people have voted. And the question is weird because it's like everything is true except, and actually HR-positive HER2-negative disease is the most common subtype. I don't know that the correct results are highlighted here.
No, we'll discuss that at the end.
Yeah, okay. So we'll go through them, but it is interesting. I mean, this is a funny question because it's except, right? So these are what you're really picking up is what has not been the case. So we got the most votes for HR positive disease, which it, of course, is the most common subtype, and single agent chemo has long been the backbone of adjuvant therapy. We know it's combination therapy. So we'll talk about this a little bit more as we get on. Okay, so now let's go on to the stop sharing. Okay, so now I've got to hide this. Sorry. It's trying to, it actually, the little poll goes up and sits in the middle of my screen, which I have to have it not do. All right. So now we're going to go on to the next one. Based on the results from the Monarch E trial, abemaciclib, a CDK4/6 inhibitor, was FDA approved in combination with endocrine therapy for adjuvant treatment of HR positive, HER2 negative, node positive early breast cancer at high risk of recurrence, with the FDA took out of the study as being specifically a key 67 of 20% or greater. According to NCCN and ASCO consensus guidelines, what factors make a patient high risk? So more than 2 nodes, 4 or more nodes, 1 to 3 nodes, and grade 3 histology, a tumor size of 5 centimeter, or a key 67 of 20% or greater, or B and C. Okay. Oh, we're getting even more votes. Very exciting. So 78% said B and C. So we'll see when we get to the end where we are with this. Okay. And then which of the following toxicities associated with oral therapies in HR positive, HER2 negative early breast cancer is correctly matched to the recommended management strategy? So patients taking abemaciclib 150 twice a day in combination with tamoxifen and develops grade 3 neutropenia that's recurrent. Hold until grade 2 or less and then resume at 100 BID. The patient is taking abema 150 BID, develops grade 3 diarrhea. Hold until grade 1 or less and resume at 50 milligrams twice a day. Patient is taking olaparib 300 twice a day and can't tolerate due to stomach upset, reduced to 150 BID. The patient is taking olaparib at 300 and is experiencing fatigue that's impacting quality of life. This is to be expected. No clinical intervention is necessary. So people are voting. There's less certainty here, I can see, because the votes are coming in a little more slowly. Just pick one, would be my thought. The one that fits into what you think the best. Okay, we had 22 answer this one. And the most common answer was the abemaciclib dose reduction for grade 3 neutropenia, or the at 32%. The dose reduction would, I'll point out, going from 150 BID to 50 BID is never going to be the answer because that's a big dose reduction, right? It comes in 100 milligrams too. So the next reduction after 300 is 200 in general, but we'll talk about this more. All right, which of the following are recommended elements of the simple framework to promote patient adherence and persistence to oral oncolytic therapy? Simplify medication, education of patient and family, evaluate adherence at regular intervals throughout treatment, or all of the above. This one is not quite as tricky, I would say. And definitely, I didn't say before, there's a Q&A section which you can drop questions into, and I'll see them because it gets highlighted, and hopefully we'll have time to talk about them. Okay, did we end? Yes, okay, good. So out of 23, 91% said all of the above, and evaluating adherence in a couple of people. So very good answers. All right. So now we're going to talk about some cases. A 54-year-old woman with a diagnosis of HR positive, HER2 negative EBC. She also has grade 3 histology. It's stage 2B, meaning she has node positive disease, and key 67 is 30%. She doesn't have any germline mutation. She has double mastectomies followed by TC chemotherapy and then starts letrozole. What additional therapeutic consideration should be made with respect to her medications? Stop letrozole and start adjuvant chemotherapy with dose dense AC. Start adjuvant abemaciclib 150 BID along with letrozole. Start olaparib with letrozole, nothing added. Letrozole monotherapy is the right choice. Remember, the patient does not have a germline mutation. All right. So most people, 52% would use abemaciclib, 28% olaparib, which we only use in patients with germline mutations in BRCA1 and 2, and PALB2, many of us, although it wasn't tested. And 4 people believe that this would be sufficient treatment. So let's see as we go along. So now let's talk about the first part, which is just our epidemiology and clinical features and how we stratify recurrence risk. The basics of early breast cancer is certainly the most common diagnosis of cancer in women worldwide, and it's the second most common cause of cancer death in the world. Estimated 288,000 cases in 2022 in the United States. And the age-adjusted rate is 87 new cases per 100,000 women. 68% of breast cancer cases is HR positive disease. So you can see that this is by far the most common. You can see a little pie diagram over here from the SEER database that is contributed to by the American Cancer Society as well. And if you look at the HER2 positive groups, it's kind of interesting. It's only 14% overall. So it really represents a small percentage of patients in who have breast cancer. And then if you look at the triple negative group, it's 10%. So these numbers are, maybe a little bit different from what we would normally think. I just wanted to highlight in the chat, the handout PDF is attached. So the 5-year relative survival percentages are listed by SEER. So this is all epidemiologic data, but you can see that if you have it's really remarkable now that 32% of patients with distant Mets are still surviving at 5 years, which is a big improvement over what we had in the past, which was in the 20% range or less. For triple negative disease, you can see it's only 12%. But the outcome now in patients with early stage disease, localized and regional, is excellent, which is really great and potentially the best numbers we've seen ever. I think in HER2 positive disease, obviously, we're going to see the highest survival at 5 years from distant metastases. But I think it does highlight, if we just go back here, if you look at HR positive, HER2 negative with regional, 10% approximately of these patients relapse at 5 years, but relapse continues. So you've got only about half of your recurrence in the first 5 years. So you figure overall at 20 years, it's going to be about 80%. So that means that a fifth of the patients will have recurrent disease. So we obviously want to optimize the treatment for these patients. So we're going to talk about 3 cases: a 42-year-old premenopausal woman who has a grade 3 HR positive tumor. She has a germline BRCA mutation, and she has stage 2A with a T1N1 tumor and a recurrence score of 26. Second patient is a 52-year-old postmenopausal woman, grade 3 again, HR positive, IDC. She's had a double mastectomy. She has a T2N1 tumor, stage 2B, a recurrence score of 35. She has type 2 diabetes, hypertension, and depression as her past medical history. And then the third case is a 66-year-old woman, postmenopausal, grade 3 IDC, HR positive, has, again, although I have to say, in this group, there's too many mastectomies because you shouldn't have a mastectomy for these tumors, especially not this woman. The BRCA mutation patient had a mastectomy because she had BRCA, but the other patients, it's, this patient with a T1 tumor and N2, it doesn't help you to have mastectomies, right? For a small cancer, even if the nodes are positive. Anyway, we seem to be liking mastectomies in these cases. So she has mastectomies and has a T1N2 tumor, and she has hyperlipidemia, and osteoarthritis as her past medical history. Okay, so our fundamental principles are that for some patients before surgery, and I would argue all but the smallest triple negative tumors and HER2 positive cancers, neoadjuvant therapy should be considered before surgery, breast conserving surgery or mastectomy, depending on personal risk as well as extent of disease. And then adjuvant therapy, of course, can include endocrine therapy, chemo, and targeted therapies, and radiation, of course, determined by multiple factors, primarily the clinical presentation before neoadjuvant therapy or at the time of surgery with the extent of disease. I will point out that some patients with HR positive disease have very high risk cancers. We've identified a group of patients who have MammaPrint ultra high risk scores or basal-like intrinsic subtype, and those patients seem to have a very high rate of PCR with neoadjuvant chemotherapy. So we're working on identifying these patients with HR positive disease whose tumors act, more like really triple negative cancers. Okay, so our old school was to look at tumor size, grade, and node involvement. Our new school is to look at these molecular prognostic indicators in HR positive disease and genomic predictors. And the combination of old and new really gives us the best information. I will say this particularly applies to HR positive HER2 negative disease. We know that the majority of triple negative cancers and HER2 positive cancers will benefit from chemotherapy and or targeted agents for both groups in at least node positive disease, and for HER2 positive disease, even node negative disease as well. So it's a little bit different kettle of fish. So now we'll focus now on HR positive HER2 negative early breast cancer with the paradigms for treatment. And the use of chemotherapy really depends on the risk of recurrence and biology of the disease. So it's not just risk-based. So having a lot of cancer doesn't mean that you're going to benefit from chemo necessarily. And we've used these gene expression tests, Oncotype DX and MammaPrint, to help us personalize therapy a little bit more. And the regimens that have been used include docetaxel and cyclophosphamide, dose-dense AC followed by weekly paclitaxel, or dose-dense AC followed by dose-dense paclitaxel. And I will say that in the neoadjuvant setting, we use paclitaxel first, followed by dose-dense AC. And in patients with germline BRCA mutations, we've also used docetaxel and carboplatin. Endocrine therapy, of course, includes ovarian inhibitors and ovarian suppression in premenopausal women, tamoxifen and bisphosphonates as a sort of an adjunct. And then novel and emerging therapies, CDK4/6 inhibitors, PARP inhibitors are now established in the early stage high-risk setting, and oral SERDs are under evaluation. So let's talk first about who needs chemotherapy. So this TAILOR-X, was a large randomized phase 3 study that evaluated patients who had node negative hormone receptor positive breast cancer using the Oncotype score to stratify treatment. So patients who had a recurrence score of 10 or lower received endocrine therapy alone. 26 or higher received endocrine therapy and chemotherapy of physician choice. And then the very large number of women, you can see that this was more than 6,700 women who had a recurrence score of 11 to 25 were randomized to get endocrine therapy alone or endocrine therapy with chemo. They had to have a high risk node negative disease. So you couldn't have a T1A tumor, for example. You could have high risk T1B or T1C or T2 disease, as long as you were node negative. It's a huge trial, 10,000 patients. And what the study showed was that recurrence risk is, we didn't look at node positive versus node negative here, but what was found was in the node negative population that if you were postmenopausal, a score of 25 or lower, you had no benefit from chemo. If you were under the age of 50 or under, and similar data was shown in MINDAC trial, that there was a suggestion of possible chemo benefit in 16 to 25 score, but the risk of distant recurrence was only decreased in patients who had a score from 21 to 25. So I think that we then weigh the clinical pathologic factors and the individual patient in terms of whether we should use chemo between 16 and 25. I think it's very unclear. And so you really do have to weigh this benefit. And I generally only consider chemo in a patient with node negative disease if the score is 21 to 25, based on the distant recurrence risk data that we have to date. Then we saw our exponder. This trial now has been published. The initial results and some updated data have been presented, but we still have a lot more follow-up that needs to be done. This randomized patients who had hormone receptor positive early breast cancer with 1 to 3 positive nodes and a recurrence score up to 25, similar. And they were stratified by a recurrence score of 0 to 13 or 14 to 25 based on Taylor-X. And patients, as you can see, about 5,000 women received chemotherapy with endocrine therapy or endocrine therapy alone. And what they saw was no benefit in any score for postmenopausal women giving chemotherapy in this group. Again, it's hard to know because there's probably a postmenopausal woman who benefits because you're looking at large groups here. But in the premenopausal women, surprisingly, there was a benefit to chemotherapy regardless of score, and it didn't make any difference whether the score was 0 to 13 or 14 to 25. However, what was found out was only 17% of women treated on our exponder received ovarian function suppression. Most of them received tamoxifen alone, although they clearly had a high-risk disease, and Soft and Text have demonstrated survival benefit with more aggressive endocrine therapy with ovarian function suppression and an AI, or even with OFS and tamoxifen in this group of women. So it's a little perplexing to me why 83% of women received tamoxifen alone. And we also, Kevin Kalinsky has shown in the analysis of this data set that the women who received chemotherapy had more ovarian suppression from the chemo at 2 years compared to the women who got endocrine therapy alone. And they weren't even looking at estradiol levels. So I think that these results are very hard to interpret. I still very much individualize my decision-making in women who are premenopausal, have 1 or 2 positive nodes and very low scores, and offer those women ovarian function suppression and an AI with or without chemo, because I just don't believe that the number of 1 to 3 positive nodes trumps everything we know about biology. And I think that this was a manifestation of ovarian function suppression. There is a trial that's opening within the NSABP, a lot of collaboration and really interesting work looking at quality of life, where patients will be randomized to all have ovarian function suppression and an AI or TAM if not tolerated with the OFS, and then chemo or not. So that will be a really important study, but we're not going to see results for many years. So ASCO recommendation for the use of biomarker testing is to use Oncotype DX, PAM50, Mammaprint. I don't think most of us use PAM50 for node negative disease. For node positive, Mammaprint is recommended because of the data from MINDAC that suggested that Mammaprint low risk score identified a group of patients with 1 to 3 positive nodes who didn't benefit from chemo. The recommendations based on Taylor-X are listed here, and we talked about that. My guideline for the less than up to 50 years old starts at 21. But, I think 16 to 20, you really have to treat women who have higher risk node negative disease because the benefit of chemotherapy is going to be quite small. For premenopausal women who have T1 to 3 node negative tumors, this just gives you some information based on stage. And if a tumor is less than or equal to 0.5 centimeters, don't send an Oncotype if it's HR positive, because there's nothing that's going to make you see benefit from chemotherapy for such a small tumor. It's not true, if you have other high risk features like triple negative or HER2 positive, where there may be some situations where there's benefit. For patients who have tumors greater than 0.5 centimeters and are node negative, I would consider the 21 gene recurrence score. I will say if you have a 75-year-old woman who has a 0.6 centimeter grade 1 tumor, ERPR 100%, you do not need an Oncotype. So you do have to always individualize this for the individual patient. And this shows you, they lump together the 16 to 25 here, as we discussed earlier. I think ovarian function suppression for any high-risk disease is incredibly important. We don't know the optimal duration, but certainly, I try and convince women to do at least 3 years. And then the node positive tumors, again, we talked about the node N1 MYC and N1, they didn't see any difference there, although in our exponder, but there weren't very many patients who had the N1 MYC disease. But if patients are not candidates for chemotherapy, obviously they might have medical problems, you're going to give endocrine therapy and ovarian function suppression. I think that the gene expression assays can help us by assessing prognosis, and then potentially trying to help the patient understand the benefit of chemotherapy if they have one positive node or a micromet, they're premenopausal and very, very low score disease. I might skip and recommend the ovarian function suppression despite what our expander shows. It has to be individualized. And then postmenopausal, of course, in scores under 25, regardless of most node status, you're going to give the endocrine therapy and no chemotherapy. For high scores, you give chemotherapy. For more nodes, 4 or more nodes, you give chemo, although, again, biology is there. And so it may be a small benefit for most women, but that's still our current guideline recommendation. You may, have patients who don't have these tests done or don't want them done. Oncotype, I'm not sure why. In the United States, we're pretty much able to get them done. In that situation, if a patient has positive nodes, it's harder to decide not to give adjuvant chemotherapy. Thankfully, in the United States, we generally have access to these tests. So now let's talk about these cases. AG is a 42-year-old premenopausal woman with a diagnosis of HR positive, HER2 negative early stage breast cancer, grade 3, with a germline BRCA2 mutation. She has a T1N1 tumor and her oncotype score is 26 and she's post mastectomy. Now, I will say these are patients that I try and treat in the neoadjuvant setting. If the tumor is node positive, I think you really gain a lot by treating before surgery. So after recovery from mastectomy, she presents to clinic to discuss her treatment. And we talked about this before. So which of the following is this case? Adjuvant chemo is not recommended. Proceed to endocrine therapy. Adjuvant chemo with TC times 4. Adjuvant chemo with dose dense AC times 4, followed by paclitaxel dose dense, or weekly, it doesn't matter. Adjuvant endocrine therapy following chemo would be recommended. So which of the following is recommended here?
So the questions throughout the presentation, we won't actually vote on. It's just for discussion.
Okay. Oh, all right, great, thanks. It looks the same, so I wasn't quite clear when you had to vote or not. So the real question here is, what do you do? And I think it's really interesting. So this is a patient, just so that you all recall, she's got HR positive disease. She has germline BRCA2, and she has a score of 26, right? And node positive disease. So in this case, I don't think it's controversial that we would be giving chemotherapy, and it's not controversial that we would be giving endocrine therapy. So to me, answer D is the appropriate answer. The chemotherapy that you choose is really up to you. I think in this situation, with a high oncotype score, many would recommend ACT. We generally give weekly paclitaxel. And again, I think that using chemotherapy in the neoadjuvant setting could be very helpful for patients like this, because you may be able to tailor down the treatment intensity based on response to therapy. Whereas if you do surgery first, you really have no idea. So now we have the second case, which is the 52-year-old postmenopausal woman who has a grade 3 T2N1 HR positive tumor. She has double mastectomies. She has some past medical history, hypertension, and diabetes. And her oncotype score is quite high at 35. So you talk to her about TC versus dose dense AC chemo. She then decides to proceed with dose dense AC. So I will say that her type 2 diabetes, depending on how bad it is, and her hypertension on medications increases her risk of cardiac toxicity from anthracyclines modestly. It really depends on how well her hypertension has been treated. And we don't know which side her cancer is. If you were going to have to do radiation on the cardiac side, that might be also a consideration. So she proceeds with dose dense AC followed by paclitaxel, but she gets she's worried. She has type 2 diabetes. She has a little underlying neuropathy, and she's worried about more neuropathy. So which paclitaxel regimen would be better tolerated? So paclitaxel weekly for 12 weeks, paclitaxel every 2 weeks for 4 doses, paclitaxel every 3 weeks for 4 doses. She should not get paclitaxel, but get TC chemo instead. So the question is, what would you do in this situation to the audience? And I'd love to see your comments in the chat or Q&A, whichever one you're able to do, to try and understand what her risk would be. I tend to give the weekly for 12 weeks in patients who are at risk for neuropathy. And I actually recommend the cold gloves and booties and emphasize both protecting the hands with gloves. You put on these surgical gloves before you put on the cold glove because you want to protect your hands and feet from thermal injury, which I haven't seen with those recommendations. But also I talk about the fact that you need gloves that fit quite snugly in order for it to work, because what you're doing is trying to reduce the circulation to the periphery of your fingertips and toes. And I have been amazed at how much better patients are doing since most of my patients use cold gloves and booties. They have to purchase them themselves, so it's a cost, which is difficult, and they find their instructions online. But there's now 3 different studies that have been reported, which have suggested that this approach reduces peripheral neuropathy. So in patients who start out with risk, that's particularly important. And this is a lifelong toxicity that can be quite destructive for patients. So now let's talk about endocrine therapy for our patients. Now, the one last thing just to mention about TC is, there has been data from the ABC trials as well as the West German Study Group trial looking at TC times 6 versus ACT and showing relatively equivalent outcomes. But when you get up to high node status and high risk status or non-HR positive disease, it does appear that the ACT regimen is clearly superior. Because we don't really have data with ACT versus TC and very high risk disease, it can be very difficult to differentiate the benefit of these 2 regimens in patients who have moderately high risk disease. So in some ways, you just have to decide how high risk the disease is and what you want to give. For like 1 positive node, I often give TC times 6 for patients who have low risk biology, but a lot of tumor burden where I'm going to need to give chemo. So I really vary it, trying to avoid AC when I can, but we can give it and support patients well when we need it. So endocrine therapy, let's move on and talk about endocrine therapy. We have a number of different treatment options. So NCCN guidelines, based on our randomized trials from this year, recommend that if you're premenopausal diagnosis, you either get tamoxifen with or without ovarian suppression or an AI with or without ovarian suppression. And then the postmenopausal women, AI for 5 years or tamoxifen to complete 10 years. Premenopausal could complete 10 years of tamoxifen. It's a little confusing, those guidelines. I think the bottom line is that for higher risk disease, if you're premenopausal, you should receive ovarian function suppression with an AI preferably, and if not well tolerated, tamoxifen. If you have low risk disease, you don't need any chemo, tamoxifen alone may be sufficient. If you're trying to avoid chemo in a patient where you think the benefit is borderline, but the patient has higher risk disease, you need to use ovarian function suppression. What do we do with extending the duration of ovarian function of endocrine therapy and assessing menopause? It can be very difficult to assess menopause because amenorrhea doesn't help us. And once you start the AI, their ovaries may kick back in again because it's providing this strong feedback to the ovaries. So you do have to watch very carefully and check estradiol if you're not sure about menopausal status when you use an AI, even if somebody's been amenorrheic for 5 years, if they still fit into an age where they could have functional ovaries. We've seen benefit from AI in higher risk early stage disease extending after 5 years, either in patients who've received 5 years of an AI or in patients who've had a switching strategy with tamoxifen followed by an AI for the first 5 years and then continued the AI. Overall, the data suggests anywhere from 7 to 10 years benefits women in this setting. For postmenopausal women, the recommendations are almost identical, except for, of course, you don't have ovarian function suppression. There will be postmenopausal women where tamoxifen may be preferable to AIs, very small tumors with reasons not to tolerate AIs. Again, this should be individualized for the patient. In terms of the decision-making of, how we decide who's lower risk or not, patients who have low intermediate risk and node negative disease, we generally give 5 years of an AI. If you start having positive nodes, so 1 to 3 positive nodes, we do extend out. There is no data, in contrary to this slide, even though the ASCO, they're just depicting the ASCO guidelines, that having 4 or more nodes is a differentiating factor versus having 1 to 3 nodes and giving 7 versus 10 years of endocrine therapy. So we don't know what the right duration is. I think that, patients who have very, very high risk disease, we do tend to use a longer duration of endocrine therapy. So, we will give, for example, 10 years for a patient who has 10 positive nodes because we know their risk of recurrence is very high. There's a lot of studies that are looking at trying to use oral SERDs in this setting to change the treatment so that we get a better feeling for, I think the best outcome and a better feeling for what we can do by changing therapy to overcome potentially acquired ESR1 mutations, et cetera. For premenopausal women, I mentioned that the data support ovarian function suppression, and there's a lot of genomic assays that might help us explore de-escalation strategies, so giving less therapy. As I mentioned earlier, this trial that's actually will open soon from the NSABP that will look at giving patients chemo or not with OFS AI who have 1 to 3 positive nodes and recurrence scores up to 25. They also will evaluate this in patients who have higher risk node negative disease as one of the groups in this study. So really important trial. So now the 42-year-old who has a diagnosis of HR positive, early stage breast cancer, grade 3, and she has the germline BRCA mutation. So she actually had a T1N1 tumor, 1.5 centimeters, and her oncotype score is 26. She gets 4 cycles of TC. Now, I will say for a patient like this, if she didn't want to get ACT, I would probably offer her docetaxel carbo, although there's not a lot of data there because of the issue that, the BRCA mutation, which has DNA damaging defect, might provide some sensitivity to platinum type agents. But again, I think you could use TC as well. She has anxiety, and she also had a provoked venous thromboembolism after a long flight. So the question is, what endocrine therapy regimen would you consider? Tamoxifen and anastrozole, letrozole, and ovarian suppression, or tamoxifen and ovarian suppression. I tend to use gaserelin, but I think leuprolide is fine. And then my choice of endocrine therapy for this patient would be an aromatase inhibitor, either letrozole or anastrozole, if she could tolerate it. She's gotten chemo already, so her ovaries are a little suppressed, which makes it easier for these women sometimes to tolerate continued ovarian function suppression. But the AIs can be tough, and if she doesn't tolerate the AI, I switched to tamoxifen after trying various aromatase inhibitors and interventions to try and manage toxicity. I do check the estradiol level at the end of each, when you're coming in to get each injection. And for very young women, I don't use the every 3-month dosing of the GnRH agonist. So now we have our 52-year-old woman who has a T2N1 grade 3 tumor. She has had mastectomies and has diabetes and hypertension. She gets dose stents, ACT, and completes radiation. And now she comes for endocrine therapy discussion. So the question is letrozole for 5 years or longer, tamoxifen 2, exemestane 3, ovarian suppression for 5. So just to go back, she has T2N1 disease, right? So 1 to 3 positive nodes. So generally, we would recommend an aromatase inhibitor for at least 5 years. We didn't talk about this earlier, but there are genomic tests like the breast cancer index that are being evaluated for longer than 5 years and have been shown to be prognostic and in a number of studies predictive in node positive disease about the benefit for longer duration aromatase inhibitor therapy. And so this can be considered as a way to make decisions in this patient population. Multidisciplinary momentum, we're talking about real world perspectives on novel therapeutics. So this is really a key area because we have so many new and emerging therapies, the CDK4/6 inhibitors and the PARP inhibitors already approved, and the oral SERDs that are being evaluated. So there have been 3 randomized phase 3 trials in the early high-risk stage setting, 2 trials with palbociclib, PALLAS, and Penelope-B. Penelope-B was a small trial, post-neoadjuvant, and a funny group of women where we know they have a higher risk of recurrence, but it's a mixed group based on a scoring system called CPG that just evaluates the sort of risk based on the residual disease. They only got 1 year of therapy, whereas 2 years in PALLAS. PALLAS included stage 2 node negative disease. So that was also an issue. There was no difference in 4-year invasive disease-free survival in either trial. But then we saw Monarch E, which is the third trial that reported. This was giving abemaciclib to more carefully defined women with high-risk early-stage node-positive disease. And then the NATALEE trial, Monarch gave abemaciclib for 2 years. The NATALEE trial is giving ribociclib to high-risk early-stage breast cancer for 3 years. So you can see that the numbers of women, over 5,600 women randomized. And we basically had several criteria. So one criteria in a small group was node positive, 1 to 3 positive nodes, and a Ki-67 of 20% or greater. The other group included patients who had 1 to 3 positive nodes and didn't have the Ki-67 as the criteria. It had a tumor size of 5 centimeters or greater and grade 3 histology. So the 2 other risk factors. So interesting that you couldn't, if you had the high Ki-67, you couldn't have the other 2 risk factors. So that study showed a clinically important and significant improvement in both invasive as well as distant disease-free survival. Now with longer term follow-up with almost all patients off study therapy. Very impressive data in both the Ki-67 low and high disease, although clearly the patients with high Ki-67 had a worse outcome with earlier risk of recurrence and a big benefit from adding abemaciclib. So this outlines this data a little bit more. So these patients had received up to 12 weeks of endocrine therapy. They were within 12 months of surgery because you had to allow for therapy and radiation, et cetera. You can see this 4 or more positive nodes or 1 to 3 nodes plus grade 3 or tumor size of 5 centimeters or greater. And then this cohort 2, just with Ki-67, smaller group of patients, about 500 out of the total group of 5,600. They received 2 years of abema, but there was no placebo control with endocrine therapy or endocrine therapy alone. Here's the data with the improvement in invasive disease-free survival, now published in the Annals of Oncology. And we're going to see updated data from Monarch E at San Antonio this year as well. So that'll be exciting to see. You can see that the absolute improvement, I think, is clinically relevant. You have a greater than 5% absolute improvement and a 30% relative risk reduction for an invasive disease-free survival event. The other nice thing to see is those curves are separating over time, and patients were off the abemaciclib, of course, at 24 months, where that first hatched line is. And then by Ki-67, you can see here the solid lines are the high Ki-67. They clearly have a worse outcome. And the dotted lines are the low Ki-67, where they have a better outcome, but both groups benefit significantly from the addition of abemaciclib. So the FDA approved in October of 21 abemaciclib now a whole year ago with endocrine therapy, and they decided high risk was node positive and a Ki-67 of 20% or greater. And the reason why they did that was the overall survival is not mature. There are toxicities and they were not including cost. So just toxicities. So they said, we're going to pick out one group of patients from the entire study and not use the study criteria, which is kind of an odd thing. But the ASCO and NCCN guidelines, all of us thought that we should really be following the Monarch E eligibility criteria. So we actually broadened that to 4 or more nodes and 1 to 3 axillary nodes with 1 or more of the risk factors listed on this slide. And that's what all of us, I think, follow in clinical practice. And the insurers have been willing to follow this as well. So that's really encouraging. The starting dose is 150 milligrams twice daily. We don't use the monotherapy dose anymore. It is affected by high acidity, so people are told to avoid grapefruit and grapefruit juice. And if you eat the abemaciclib with a high fat meal, you can increase your exposure to the drug and therefore increase diarrhea. So there are tablets that go 50, 100, 150, and 200. In the clinical trial, the dose reduction went from 150 twice a day to 100 twice a day. I have sometimes used the 250 milligram dose, so 150 in the morning and 100 at night, but the trial used 100 BID as the first dose reduction. Clinical monitoring, including standard labs every 2 weeks for the first 2 months and then monthly for 2 months. Then as indicated, usually we continue with our monthly or every 2 or 3 month labs just to make sure everything is okay, even every 3 months. And then magnesium, of course, should be kept an eye on in patients with diarrhea. The adverse effects primarily are diarrhea, but we also saw deep vein thrombosis, particularly if abemaciclib was combined with tamoxifen. So we like to avoid that combination. And also that could be associated with pulmonary embolism. And then neutropenia can be seen as well. These patients are post their adjuvant chemo, and radiation. So sometimes they would be more sensitive to that. But we don't see a lot of neutropenia with abemaciclib that needs managing in general. For hematologic toxicity, if patients have grade 1 or 2 neutropenia, we don't do anything, standard with other chemo. Grade 3, we withhold until toxicity resolves to grade 2 or less and restart. And I found that works really well. They get farther out from their radiation and chemo, and they just do fine. If they have a second grade 3 or grade 4, so less than 1,000 or less than 500, you dose reduce after they recover to the next lowest dose. So if you were on 150 BID, you go to 100 BID. We don't give growth factors except for if people have serious toxicities or they're going to need surgery or something like that. And in that situation, we hold the drug for at least 2 days after the last growth factor dose to avoid sort of enhancing cell turnover with the growth factor and then cell death with the abemaciclib. Again, if you need a growth factor, you should dose reduce. Consider dose reducing to the next lower dose level when you restart. For GI toxicity, what's really important with GI toxicity with abemaciclib, as it's the most common toxicity, is education. It is so incredibly important. Women need to know that. I think there's a much greater awareness because of the data from Monarch E now than there was before. And the idea is that no one should go home with abemaciclib without having loperamide in their pocket. And then we do tell people that the diet makes a really big difference. So they should avoid leafy green vegetables, raw vegetables, very spicy food in the first few days and weeks after starting abemaciclib when they're getting used to the diarrhea, because it really enhances the diarrhea if they go home and eat a big salad. And then you can see that grade 1 diarrhea is increase of less than 4 stools per day, 4 to 6 for grade 2, and greater or equal to 7 for grade 3. And of course, grade 4 is life-threatening. And if you have grade 1, you manage with trying to manage diet and giving more Imodium. If you have grade 2, you hold until they feel better, and then you can start again at the same dose if patients weren't taking enough Imodium or something unusual happened, they got a viral syndrome or something like that. If you have recurrent grade 2, you want to dose reduce. Grade 3, generally, we dose reduce for, particularly if nothing unusual has happened and patients have been taking their antidiarrheal medication. So this is a really important point, and it helps maintain adherence. Other toxicities, ILD, interstitial lung disease, we now know from TDXT, it's been reported with all 3 CDK4/6 inhibitors. You don't need to modify for grade 1 or 2. But, if somebody has symptomatic grade 2 toxicity, I would hold the drug and give steroids, any symptoms. You can start, if it's low grade, if grade 2 goes away right away, you could re-challenge. For grade 1, we don't do anything, but just keep an eye on it. We see it all the time. Grade 3, you can't restart. I think, if somebody has really significant grade 3, the guidelines here say you wait till it gets better with steroids, we usually treat, and then resume at the next lower dose. But I think you have to be very cautious in treating patients who have grade 3 or 4 ILD. This is something we rarely see, and they're very sick. I would retreat with grade 2 that resolves to baseline. Again, this has to be individualized. When we looked at the rate of discontinuation, the factors that contributed, you can see here, why people discontinued. So the discontinuation rates are listed there. And, it's interesting, where more patients were enrolled, there was a little bit more discontinuation, premenopausal versus postmenopausal. So the premenopausal women, presumably, they were more worried and have higher risk disease, and they discontinued less, interestingly, than the postmenopausal women, 18%. They were sort of frustrated with disease. 65 years or older, almost a 28% rate of discontinuation in those 430 women. No difference in ECOG status or number of nodes. I think the big difference with number of nodes is that you see that, there's a trend as you increase risk by having more nodes, there's less discontinuation, which makes sense. And then comorbidities. If you have a lot of comorbidities, which were defined for this analysis, there's more discontinuation, double than having none, 18 versus about 10%. The majority of patients who discontinued did so in the first 6 months. Big fall off in the first 3 months due to diarrhea that wasn't well managed. And now that we have more education, I think it really makes a big difference in adherence. Okay. See if I can make a change. Okay, so dose reductions, very helpful. And in clinical practice, you're not on a trial. You could dose reduce. It's great. I mean, you can just say, oh, we'll just dose reduce you 100 twice a day. If you don't tolerate it, we can go down further. If you tolerate it and you feel better, we can always go back up again. And you can go to 150 and 100. So 250 milligrams. You have a lot of, leeway here. If you can't tolerate 50 twice a day, you should discontinue it. So I mentioned education is really key, and it's incredibly important to have supportive care medications. We don't see a lot of nausea with the abemaciclib, but it's good for patients to have some nausea medication for rescue, and the loperamide dosing is incredibly important, and calling in, because you don't want them managing all this diarrhea at home and not calling in. So they got to know, take the loperamide and call us, and hold your drug if you're having a lot of diarrhea, just in case they can't reach anybody or they're without cell signal, who knows. So this patient too, she starts letrozole for 5 years and is given abemaciclib. This is a patient who I think all of us would give abemaciclib to. She has a T2N1 disease with a high score and a high risk disease. So she does qualify for abemaciclib. So she's going to begin abemaciclib. What's the following supportive care medication she should have access to at home? Loperamide, diphenhydramine, ondansetron, or bismuth subsalicylate. So I think all of us would agree here that loperamide is the right drug to have access to here. It's incredibly important. As I told you, they need to have it before they put that first pill in their mouth and to have done education. She begins it. Her ANC is 1200 after 2 weeks. What would you do? Grade 1, continue abema. Grade 2, hold abema. Grade 2, continue abema. Grade 3, hold abema. So a lot of this has to do with grading, but obviously you're going to continue the abemaciclib. It doesn't really matter which grade you call it, but it's grade 2. And but in this case, if your neutrophil count is 1,000 or higher, you continue and just watch the ANC. You don't need to make any other change. So what about promoting adherence to oral oncolytics? Understanding is so incredibly important. The regular administration, how to manage side effects. You have to give them the tools to understand how to take their medications and why it's important. Direct questions about, are you taking your medication? How many times during the month were you unable to take the medication? Things that don't make them feel guilty, but help them share with you that information. And your explanations need to be very clear and tailored to the level of patient education, their so-called health literacy and the therapeutic importance. So one of the things is, I send a lot of my so-called survivorship patients to see my nurse practitioners on a regular basis, and they help a lot. But sometimes when patients are really feeling very frustrated, they'll do an extra visit with me so that we can go over, and I usually show them graphics from recent published data. I found TAILOR-X and RX responder curves are really helpful, and just try and tell them why the hormone therapy is so incredibly important for them and why we're giving them abemaciclib, and then work with the patients. There is this very nice publication from summarized here. You can see the references at the bottom from 2020 that just talks about simplifying the regimen, imparting knowledge, modifying patient beliefs, patient and family communication, trying not to take out the bias from our side versus theirs, and evaluating adherence. We don't generally pill count, measure serum or urine levels, et cetera. But I think that it is really, really helpful to ask patients about their adherence in the least threatening way possible. It makes a big difference. Some people use medication event monitoring systems. Again, we don't generally do that in breast oncology. So she presents back, she's doing well, and she does tell you that she misses about 4 doses per week because she forgets the abemaciclib. So one question is, how can we help her? And I think, one is identifying the barriers. Is it because she needs to rush to take her kids to school in the morning? Does she forget to take it at night? A lot of times I'll look and see when patients last refilled their drug. That's very helpful too, both for these medications and narcotics. It's usually not cost if you miss 4 pills a week. Is it side effects that bother them? I tell them to use a pill box. I also tell them to write it on their calendar because most people have smartphones now. They can put it on alarm if they're forgetting a lot, and that makes a really big difference. There are even apps that help people send up a little reminder to say, did you take your pill? Case 3, let's see if I don't know that my cursor will let me look. Let's see here. How do you stratify recurrence risk in your practice? Do you follow the FDA label? Oh, for abemaciclib, I follow the ASCO NCCN definition. I will say that I was a steering committee member on the Monarch E trial and published the toxicity management data recently with Sarah Tallaney. And I really feel strongly that these are patients who are at high risk who benefit from abema, so I don't follow the narrow FDA guidelines, which none of us really could understand, even after talking to our friends in the FDA. So I just feel like, these patients, they recur, they fill up our clinics with recurrence. And if you can get them through 2 years of abemaciclib, there's clear benefit with longer follow-up in Monarch E. Although I know the FDA tried hard to do a good job. So here we have our third patient, the 66-year-old who has a grade 3 IDC and T1 and 2. So she's got a lot of nodes, 4 or more positive nodes. She has hyperlipidemia and osteoarthritis. She gets 4 cycles of TC. I might have given her 6, depending on how she would have done. I generally do for 4 or more positive nodes. She's going to go on anastrozole for 5 years and zoledronate for 3 years. The oncologist discusses abemaciclib because she clearly fits into our Monarch E recommendations for 2 years. Here you can see what you would do when she comes in with diarrhea and abdominal pain. It's at 1 week, and this is very common. She's having 5 loose watery bowel movements per day, baseline of 1. Which of the following is correct? Hold abema for grade 3, start tincture of opium. Grade 2, hold abema, start loperamide. Grade 2, continue abemaciclib, start loperamide. Grade 1, continue abema, start loperamide. So this clearly is not grade 1, right? And she has a baseline of 1. You've increased by 4, so she's grade 2. In this situation, I will usually have people, if they're not taking abemaciclib, loperamide, I'll have them start loperamide and see how they do. I often will have them skip a dose or 2, although I'm not holding it for a long time, if they're 65 and really having problems just because of the abdominal pain, not because of the diarrhea. And then they get it under control and restart, and they usually do fine. We talk about their diet. We talk about using a sort of less roughage-like diet for the first few days after restarting. And then I have found all of my patients, with the exception of very few, who are taking abemaciclib in the adjuvant setting, take at least a half an Imodium loperamide a day. So somewhere between 1/2 to 1. And then often when they eat a salad, they take another half or 1. So managing it that way with prophylaxis, to me, works the absolute best, rather than taking it in response to diarrhea, because they just don't do well in that way. All right, now what about Olympia as we finish up here? We're going to try and finish right exactly on the hour. So 1,800 women who had germline BRCA mutations were randomized to receive olaparib or placebo for 1 year, and triple negative breast cancer, high risk, hormone receptor positive disease, no PCR, or this scoring system of greater than 3 or 4 positive lymph nodes or more. So that was a smaller group, 325 patients with, it's interesting, most of them had BRCA1 mutations, most were triple negative. But when you looked at the subset analysis, patients benefited regardless of those differences. So 3-year IDFS was markedly improved. I mean, huge benefit. In the hormone receptor positives cohort, as I mentioned, there was still more than a 6% absolute benefit. In triple negative breast cancer, it was a little bit greater, just under 10%. But you can see these curves stay separated over time. And then overall survival was also improved based on the most recent data presented at ESMO in a plenary earlier this year. And you can see that in the hormone receptor positive group, the hazard ratio was 0.68, similar to the entire group. Although the hazard ratio did cross 1 in the hormone receptor positive group because it's just too early. But the p-value was significant for the whole group and led to FDA approval for olaparib in any patient with high risk breast cancer with a germline mutation. The FDA approved this. You can see here, high risk early stage breast cancer with neoadjuvant or adjuvant chemo. And the NCCN guidelines, 4 or more positive nodes, residual disease after pre-op therapy, or tumor grade high, this CPS plus EG score of 3 or more. The dose is 300 milligrams twice a day. It comes in 100 and 150. And the adverse effects are primarily anemia, but patients can get diarrhea, nausea, and vomiting. And in Olympia, again, Mostly it was low-grade nausea overall, and as well as diarrhea. And the primary issue, which was small, was anemia. Very few patients required transfusions, and taking the olaparib with food and taking antiemetics as needed work very well. And you reduce down to 250 twice a day first if patients have GI toxicity, from 300 twice a day. So this patient patient case 1, we've gone back to oncotype score of 6, BRCA2, completes 4 cycles of TC and radiation, starts an anastrozole and GnRH agonist. She's had a venous thromboembolism. So now we recommend that she would get olaparib. Insurance approval is obtained, but 1 week later, she has uncontrolled nausea and is thrown up 3 times. So you want to make sure she's taking the olaparib with food, give her scheduled ondansetron and prochlorperazine, or all of the above. And, I would do all of the above. But the one thing that I would do that's not listed here is give olanzapine, the antipsychotic, at 2.5 milligrams at bedtime. I found that to be incredibly helpful for patients who have nausea with olaparib, and it allows them to take less than the every single dose of olaparib ondansetron, which gives them constipation and sometimes a headache. So I found that works really well. So the next thing are the NATALEE trial. We talked about giredestrant as SERDs, as well as other SERDs actually are going to be. Luminestrant will be evaluated in the extended adjuvant setting. And I'm sure camizestrant, which just reported in a press release, a positive phase 2 trial, will be evaluated. Pembro and chemo, of course, there's an adjuvant trial going on, and cell-free DNA to evaluate for minimal residual disease. And shared decision-making, as we just finished here, is important to empower patients to make health-related decisions, to integrate personal preferences with provider guidance. Very, very important. So we've learned a lot today. The backbone of adjuvant treatment is evolving. We're making big advances. Very exciting time. We're trying to evaluate the need for chemotherapy, and I think we're going to see a lot more genomic criteria as well as others in the near future. Adherence is critical, and management of toxicity is also critical, with abemaciclib for high-risk disease and olaparib for patients with germline BRCA1/2 mutations.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and, most importantly, for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.